Assalamu alaikum, good evening, and welcome to this special webinar today. We'd like to join us under the umbrella of our society, the Scientific Society of Infertility Treatment Technologies, with the sponsor of أثينا الشركة الرائدة في مجال الأدوية, and with the share of our colleagues and our teachers. And we hope to enjoy this webinar because it is very important subject, especially in our society, that we refuse that, or our society refuse the surrogate, which is الأم البديلة, and we hope this subject nearby or far, we don't know, maybe according to crises that occur in the world, maybe it look like the kidney transplantation. I leave the stage to my colleague, Dr. May Abrghif. Thank you very much.
مساء الخير. مساء الخير. نرحب بكل الحضور في هذه الأمسية العلمية برعاية جمعيتنا الجمعية العلمية للتقنيات معالجة العقم وشركة أثينا الرائدة في طب الأدوية. نيابة عن نفسي وعن جميع الحضور نرحب أجمل الترحيب بالدكتورة غادة حسين لتشريفها لنا وتسليط الضوء على موضوع مهم جدا يخص العقم والتقنيات الحديثة في معالجة العقم، ألا وهو the Uterine transplantation stage. Stage for you, دكتورة غادة, please.
أهلا وسهلا وشكرا جزيلا لإتاحتي الفرصة أن أكون وياكم اليوم، وإن شاء الله أقدر أقدم الموضوع بالطريقة اللي يعني تقدرون يعني تكون مفهومة، وبنفس الوقت إذا أكو أي سؤال أو أي شيء خلال فترة إعطاء المحاضرة أنا ما عندي مشكلة، أو ما بعدها طبعا. والمحاضرة اللي حضر ويانا بالمؤتمر أنا لقيت هواية معلومات من عندها، بس راح أحاول أعيدها وأتعمق أكثر بالأمور اللي موجودة بيها. راح طبعا أكون أتحدث باللغة الإنجليزية، بس ما عندي مانع إذا كان أي سؤال باللغة العربية أيضا أجاوب عليه. So today I'm going to talk about the uterus transplantation program and wondering whether it is possible to be settled in Iraq. This is the disclosure statements of mine. I am a consultant OBGYN from Värmland province, and then IVF specialist from Gothenburg, and the medical director of Stockholm IVF Clinic in Stockholm, affiliated researcher in Cleantech in Karolinska Institute. After this presentation, I hope that we can be able to know about the ethical consideration of the uterus transplantation, the patients and principles of this procedure, the experience of live donors and deceased donors, and the surgery of both donor and recipient uterus transplantation, the immunosuppression, the efficacy and safety of assisted reproductive technologies and obstetrical outcomes, the IVF treatments prior to and post UTX with embryo transfer, the reproductive and live birth outcomes after uterine transplantation, and finally to see what we need to do in order to get this program settled in Iraq. You know that the inability to get pregnant and give birth and have a child, it's a kind of traumatic and devastating situation in the world, and especially for the couple and even for the community. And one of the causes for this problem is absolute uterine factor infertility, and this can aid it's about 3 to 5% of the population, more than 1.5 million of women worldwide affected by this problem, and 2,000 to 3,000 potential uterine transplantation patients in Nordic countries found nowadays, and even more in the United Kingdom. Why this, or what are the causes beyond this factor? Either we have no uterus at all, the patient born with no uterus, in case with Mayer-Rokitansky syndrome, or she had a uterus and because of some kind of complication during her life or problem, we were enforced to do hysterectomy for her, like in case of obstetrical complications and bleeding, or in case of stool or big fibroid, or in case of cervical or uterine cancer. Or there is uterus, the uterus is present, but it's not functioning in case of intrauterine adhesions, like in Asherman syndrome, or there is radiational damage, or there is a big fibroma or fibrosis, and there is malformations or severe adenomyosis. All these cases actually are candidates for uterus transplantations. And I have to mention an important thing now, because some of the countries have high percentage of cesarean sections. The complications of the pregnancy and the delivery is getting higher and higher, and ending with hysterectomy. And after a few years, if this procedure is going to be settled, there will be more and more need to do it later on. So what we have for options to these patients, or to those patients that have absolute uterine factor infertility? Either we have surrogacy or uterus transplantation or adoption. Otherwise, they will end with lifelong infertility. In 2009, FIGO came with the first ethical guidelines to uterus transplantation. They stated that uterine transplantation, which may reach only clinical experimental stage, should not become until after adequate and significant research in appropriate large animal models, including even the primates. And it is unethical to remove a uterus for transplantation from young woman if she is not being able to complete her family first. And finally, given the lack of data and safety and non-hazards to live donors, the procedure was at that time still considered as ethically inappropriate. So between 1999 and 2012, we got a lot of animal studies, including the mouse, rat, pig, sheep, and baboon. And the same year, the ethical considerations from FIGO come, we got the ideal concept, which means the idea of getting animal studies, starting with a small number of patients under strict research criteria and protocols with well-informed consents and approval. Then we have to go to the development with prospective experimental study and ethical committees. We have to explore and analyze the results and assess them, and after which we have to do long-term studies. This is how we started with mouse uterus transplantation and ended with successful pregnancies later on. And after that, we have a lot of animal studies on the rat and even on the sheep, with also successful pregnancies and deliveries. So in 2012, after many years of animal research and studies in Sweden, together with Professor Mats Brännström and our team, we started the first case series research on human uterus transplantation using live donors. Why uterus transplantation come too late to the practice? Because uterus is a dynamic, complex organ. It is highly blood flow dependent. It warrants many additional clinical concerns like IVF, surgery to the donor and recipient, immunosuppression, and then it's not lifelong. Hysterectomy of the transplanted uterus after 1 to 2 childbearing or 5 years should be performed later. It's expensive and there are other alternative ways. And it's, as I said before, not life-saving, but it is actually life-improving surgery. That's why it came rather late. Talking about the history of this procedure, in 2000, the first uterus transplantation procedure was done in Saudi Arabia, and it was performed from a 46-year-old hysterectomized patient into a 26-year-old recipient. But the transplanted uterus just functioned for about 3 months, and then they were enforced to remove it later on. In 2011 in Turkey, the world's first uterus transplantation from a deceased donor was conducted, and 2 years later, they were able to announce the first pregnancy, but unfortunately this pregnancy was terminated at week 6 because of heart failure. In 2012, as I said before, in Sweden was the first clinical trial of transplantation involving 9 women who received uteri from live donors, and the first mother-to-daughter womb transplant was done by our Swedish colleagues. And in 2014, we announced for the first time in the world, a healthy baby who was born to a uterine transplanted uterus. And this is Professor Mats Brännström, and this is our team and colleagues, and this was the first baby that was born then. Later on, over 80 uterus transplantation procedures performed all over the world, with a surgical successful over 70% and live birth rate successful per successful uterine transplantation was up to 80%. And these are the countries that perform nowadays uterus transplantation, and among which we have Lebanon as an Arabic country as well. The other countries supposed to start from 2022 and ongoing is United Kingdom, South Korea, and even Egypt is trying to be one of these countries, Arabic countries as well. So actually, what are the principles of this uterine transplantation? We have 3 important steps or stages the patient and the process and the procedure go through. The first one is the pre-transplant, where we have to counsel the patient, find them and enroll them. We have to screen them. And then we have, after we accept this patient as a recipient, we have to do the pre-uterus transplant, IVF, and create the embryos and preserve them. Later on, we have to find the donor. And after getting the right donor, we have to do the transplantation to the recipient and give the immunosuppression, which is the transplantation step or period. And after good clinical follow-up and stable immunosuppression, then we have to start to transfer the embryo to the recipient and make her pregnant. And then now come the post-transplant period, where the pregnancy should be well controlled and the delivery should be by cesarean section. And after about 1 to 2 childs or 5 years of having the transplanted uterus, hysterectomy should be performed later on. And then we have to check the psychological well-being of both the recipient and donor later on. So as I told you, we have to start with getting patient enrollment and screening. And if we found one of those patients I mentioned previously with absolute uterine factor infertility, then we have to check the general medical condition and the general psychological condition, the reproductive assessment, because we cannot enroll a patient who doesn't have functioning ovaries, and we have to go through the consent form and make sure that the recipient is understanding everything in this procedure. Then, as I told you, we have to do the IVF treatment before the transplantation. Why we should do it? Because it confirms the fertility potential in the recipient. It minimizes the risk of iatrogenic injuries related to oocyte retrieval after uterine transplantation surgery, and reduces the exposure time to immunosuppressive therapy. Before the IVF treatment, we have to take hormonal assay and analysis like FSH, LH, estradiol, and progesterone. We have to check the AMH, especially if the patient is with Rokitansky syndrome, because they have maldisposition of the ovaries and may have non-functioning ovaries. We have to detect the ovulation time by ultrasound and following LH surge. And we use 2 different ovarian stimulation protocols here in Sweden. And this is the long GnRH agonist protocol or the random start antagonist protocol. Then we may be able to retrieve the eggs either transabdominal or transvaginal later on. This is the long GnRH agonist protocol. Because the patient don't have any menstruation, then we have to detect her ovulation by ultrasound and LH search. And then about 1 week later, we can start with the GnRH agonist. We use spray here in Sweden. And I know that in Iraq and other Arabic places and Middle East, they may use either gonapeptyl or decapeptyl 0.1 subcutaneously daily, or just one bolus dose of 3.75 long-acting gonapeptyl 1 week before the expected menstruation. But if we are dealing with a patient that don't have menstruation, then we have to detect the ovulation, and 1 week later we can start with this agonist, and 2 to 3 weeks later we have to take the estradiol level. If it is less than 100, then we can start the gonadotrophins in about 10 to 14 days with serial ultrasound control. When it is accepted, the number and the sizes of the follicles, then triggering will be by HCG, by ovulation induction, like Uterine. And 36 hours later, we pick up the egg the same way we do. If it is not impossible through vaginal, then we do it abdominally, and we try to freeze 8 to 10 good quality embryos. First, we started with day 2, day 3 and blastocysts, but later all the procedures prefer only blastocysts. The other procedure is the random start IVF treatment. And in 2015, actually, I, together with my colleague, published first, it was in the beginning, we started to use them for cancer patients. I published the first case report in a patient during cytotoxic treatment, and after which in Sweden we were able to use this protocol more and more to preserve the oocytes, especially, and embryos, especially to, as I told you, to cancer patients. And even now we do it for social egg freezing till ladies. The random start IVF protocol means that you can start at any time of the cycle, nevertheless the ovulation or the menstruation, but you have to start at the same time with the antagonist, and you go through it as usual, 10 to 14 days, and do serial ultrasound. But if you are going to do the ovulation triggering, if the patient overstimulated, then it's better to give GnRH agonist rather than HCG. And then proceed the same way we do with other IVF treatments. Which types of donors we can use for this procedure? In the beginning, we used only the live donors, but later on it becomes very easier to even to do it with a deceased donor if possible and if available. The live donor is we have to take fully medical history, and it's available. The advantage of it is that we can plan for the surgery ahead with a prepared multidisciplinary team. And the cold ischemia time can be kept short with this donor. And the hysterectomy can be done either by laparotomy or by laparoscopy and robotic assisted laparoscopy. Most of the donors used in our trial were mothers or mother sisters, mother-in-law, or even family friend. They should have BMI less than 28. They shouldn't have any systemic diseases. They should have at least 1 or 2 normal pregnancy, 1 cesarean section accepted, but not more, and no malignancy in the history. While the deceased donor, also called multi-organ donor, this donor is not exposed to any surgical risk. It's easier surgery, good access to long vasculature pedicles with large diameters. This is to be used for the anastomosis, and the hysterectomy is always performed by laparotomy. The reports of the deceased donor uterus transplantation come from 11 cases. They were published, including publication from Czech, from USA, from Brazil, and Turkey. The overall surgical success in these 11 deceased cases were 64%, And this success defined as surgery without any incident or post-transplant normal blood flow and regular menstruation to the recipient after that. While the reports of the live donors come from 51 live donor cases, starting from 2000s and ongoing, 18 published cases from USA, 17 in Sweden, 5 in Czech, 4 in Germany, and the rest singles, Saudi Arabia, China, Lebanon, and Spain. And the surgical success was 78%, with a slightly higher success rate with laparoscopy and minimal invasive surgeries, with 89% than in laparotomy cases, 73%. And here you can see the first 5 cases or first 5 trials were only with deceased donors, and then these are the live donors, and among which we have the Swedish trial, where we get 6 out of 8 of them pregnant and get a baby delivered. Now, talking about the surgery of the donor, we have to isolate from the uterus bilaterally long venous and arterial vasculature pedicles. And we have to do extensive vascular dissection to include the distal parts of internal iliac veins and arteries. You can see here both sides. And after surgical isolation, the uterus should be flushed bilaterally through the arterial ends with a cold solution. And this cold solution, if it is longer than usual, it may cause damage sometimes. That's why with the live donor, this cold ischemia or cold damage is much less than in case of deceased donor. And the donor surgery is rather long and complicated. May take 10 to or let me say 8 to 12 hours. These are our 9 cases, and you can see how long it took. So it takes about, as I said, 8 to 12 hours, but some of them we may even have some complications like uterovaginal fistula, urinary bladder hypotonia, ureteric laceration, vaginal valve prolapse, or ureteric blood clot with secondary hydronephrosis. While the recipient surgery is much easier and takes less time, no blood transfusion required, no ICU, and the hospitalization was only 4 to 9 days. It's about 4 to 5 hours. It's less complicated, but still we can experience some complications, especially vaginal stenosis over the end-to-end anastomosis between vaginal rim of the graft and the vagina of the recipient. In Sweden, we get this 13% among successful grafts in the laparotomy, but it was a little bit higher when we use laparoscopy or robotic laparoscopies. While in other countries, you see this complication reported much higher than in Sweden. The vaginal stenosis makes it difficult to obtain cervical biopsies for rejection diagnosis, as well as difficult to perform embryo transfer. The other complication is the graft rejection. It's frequently seen after transplantation, with the majority being minor to moderate in sensitivity. And it's always reversible by increasing the immunosuppression. Just occasional cases of severe rejection has been reported, but no one required the removal of the graft because of this rejection. Regarding the immunosuppression, we always start with a bolus of IVF corticosteroids, and then we do maintenance by tacrolimus and mycophenolate. This discontinued after 8 months and changed to another form of immunosuppressant. I'm not good in the names of these immunosuppressant. Actually, all this immunosuppression is performed by a well-experienced immunologist and internist. At pregnancy, oral prednisolone was added, and monitoring of the uterus was by gynecological examination and taking cervical biopsies first month, twice weekly, and then from month 2 to 6, it was every 2 weeks, and later on it was monthly. And whenever you get any rejection, you have to start giving again the immunosuppressant and perform the biopsy later on after 2 weeks. Talking about the embryo transfer in these patients, the time required for the first embryo transfer in the beginning was 12 months after the procedure, until we are satisfied about the stability of immunosuppression to the patients. We couldn't perform any embryo transfer. But later on, this interval has been shortened and shortened, and nowadays 3 to 6 months enough to perform first embryo transfer after uterus transplantation. Almost always we used frozen embryo transfer. This was the vast majority of the patient because, as I mentioned previously, we do prior to transplantation IVF, and we preserve 8 to 10 good quality embryos. So we start always with the frozen embryo transfer, except in some cases where we require to do post-transplantation IVF, and I'm going to talk about it later. So this was performed after following the ovulation time by ultrasound and LH search. If we have day 2 embryo, then we have to add LH plus 3. If we have blastocyst, it will be LH plus 6. In the few patients with non-detectable LH signals or irregular cycles, programming the cycles by HRT or hormonal treatments is required now. Single embryo transfer should be compulsory in these patients. Why? Because transfer of multiple embryos will markedly increase the risk of multiple pregnancy, and this is lead to increase the risk of obstetric, neonatal, and postnatal complication to those patients as well. Moreover, the pelvic fixation of and vascular supply of the transplanted uterus cannot withstand the multiple pregnancy, and it will be larger risk for many complications during the pregnancy. What are the special concerns of embryo transfer in these patients? We found that some of the patients, after 2 to 3 years, they start to have long cervix. Not as the usual. The cervix tends to be more longer than normal, and it can be up to 10 centimeters sometimes. So we need to have longer catheter for the transfer, and we absolutely to do the transfer under ultrasonic guide in order not to place the embryo in the wrong place or the wrong situation. So this post-uterus cervix hypertrophy or trophy, this may be secondary to increased uterine blood flow and the shunting of the blood through the well-sized anterior portion of the anterior iliac uterus. The other concern is that we found some of the patients have very acute degree of cervico-uterine angulation, and this is because of the adhesions where the uterus attached to the abdominal wall and get this very extreme antiflexion position. And this also will give some difficulty during the embryo transfer. And the third and other concern was, as mentioned, this stenosis over the vaginal anastomosis. It makes it very difficult to find the orifice and perform the embryo transfer in the right way sometimes, as well as it is painful for the patient herself. How to deal with these concerns? We have to do mock transfer before any proper embryo transfer. We have to use extra long embryo transfer catheter with ultrasonic guide, and it should be only performed by a well-experienced IVF specialist. And this IVF treatment after uterus transplantation can first we used to use the embryos that are found in the freezing system, but when we exhaust all the pools of embryos, or there are other social cases or specific cases where the husband dies or the couple separated, then we have to do another IVF treatment post-transplantation. But the patient should have good ovarian reserve. She should be stable with a functioning transplanted uterus, and her medical condition and psychological conditions should be as well stable. What are the specific challenges with post-uterine transplant IVF? The altered position of the ovaries after this surgery can make it difficult to perform egg retrieval transvaginally because the ovary sometimes is displayed upwards, so we have to do it through the abdomen. The changed pelvic vasculature can lead to higher risk of post-operative intra-abdominal bleeding and the greater susceptibility to pelvic infection after ovum pickup due to immunosuppressive state of the women also makes it another risk factor. But what are the advantages of this procedure? The major advantage of this procedure is that we are able to start the stimulation in an optimal time because the patient starts to menstruate and we know exactly where we are in this menstrual time. And the ability to do fresh embryo transfer, which also can have a better chance if the frozen embryo not survive after the thawing. And finally, the reassurance to the patient's fertility potential is also being able, especially in case of social crisis. And you can see here the patients that we used. Some of them used two IVF treatments and get 2 babies, not only 1 baby. And almost all of them, except 2 of the first trial cases, couldn't be able to have a baby, of which one of the patients get multiple missed abortions, about 4 or 5 times we couldn't find the cause actually, but finally we were we weren't able to make her pregnant and continued until delivery, and finally the uterus was removed. The live birth per patients was about, for 7 patients was 19, and for the other only 6, because one of them get 2 babies, it was 30%. And if we take the cumulative pregnant or live birth rate, which is very important here, because if I have a patient that I'm going to do uterus transplantation, that I have 5 years duration to consider the pregnancy rate. So if she's going to get pregnant 2 times or 3 times during these 5 years, this is important for me to know, not only just per embryo transfer. So the cumulative pregnancy rate was 85%. Per successful uterus transplantation, and per attempted uterus, because we have 9 and only 6 could be able to be pregnant, it was 66%. 2/3 of the cases could be able to get pregnant and deliver a baby. And how we can define the safety and the efficacy of IVF outcomes in uterus transplantation. 22 studies all over the world we could collect with about 52 uterus IVF trials. Regarding the safety, we could get 73.1% of the surgical procedures safe, and about 23.1% of the recipients experienced post-operative complications, and only 3.8% of procedures failed before uterine recipient surgery due to intraoperative complications. The outcome endpoints, which should be evaluated, as I mentioned previously, should be the cumulative clinical pregnancy rate and the cumulative live birth rate. And the efficacy of uterus transplantation IVF was 42.1% based on the number of live birth per successful procedures, not per embryo transfer. Regarding the obstetrical outcomes, also a very important endpoints is the pregnancy duration, the birth weight, and the preterm birth, the neonatal complications, or the occurrence of any congenital malformations of the babies were also considered. We have the IVF uterus transplant IVF pregnancy led to 16 deliveries, and all of them were healthy, but we had some form of major complications It was in 1/3 of the cases, and in 2/3 of the cases, we had preterm birth and deliveries. And here you can see, although almost all the patients except 1 or 2 get preterm deliveries, all the babies delivered were healthy, and they had very good APGAR score, except this one, which was rather very early preterm. It was started with 3, 7, and 10, the APGAR score of the babies. But all of them are living now and healthy, and no problem could be reported. Later on, there was a kind of survey or a search about the public attitude and the ethical issues. And in Sweden, as well as in USA and in Japan, we tried to ask the infertile population about their thoughts, whether adoption, whether surrogacy or uterus transplantation better, which one was much better or more preferred from those patients. And when we did all these surveys and researches, almost all the patients were in favor of having uterus transplantation rather than surrogacy or adoption. And finally, I will conclude that the uterus transplantation has entered the sense of the first available treatment for absolute uterine factor infertility. It is no longer in the experimental stage. It starts its clinical performance in many countries, and every single donation in the beginning is difficult, but later on it becomes easier and easier, and we can see now we deal with them much easier than previously. The procedure is still although it is still in the experimental phase, but ongoing clinical pregnancy clinical procedures and modifications and widespread clinical use of this is now found all over, as I said, all over the world with very improved results, considering cyclical changes of the endometrium and the subendometrial tissues with the variations in composition and immunological active cells. The time required now we consider it's 5 years, and previously it was only 1 child. Now we can say it's even up to 2 child or healthy babies could be performed with a transplanted uterus. And finally, the uterine transplantation is considered more socially and individually acceptable for women in reproductive age than surrogacy and adoption. And my last slide and discussion, how we can be in help to settle this program in Iraq. Actually, in order to settle this program in Iraq, we need either a special center that is located in a tertiary hospital, or maybe a common donation center. I mean, the same center used for kidney transplantation and other organ transplantation can be used for uterus transplantation, but this center should be located in a tertiary hospital with the access to other important specialties, especially because we need this multidisciplinary team. We need surgeons, we need oncogynecologists, we need immunologists, pathologists, psychiatrists, reproductive endocrinologists, IVF specialists, and fetal-maternal specialists. We need the authority approval, and we need the affiliation with a well-experienced international team. I think in Iraq, Madinat al-Tib is one of the big tertiary hospitals, and it's not difficult to have such a center there if someone will start this program. And the multidisciplinary team, أطباءنا العراقيين ما شاء الله عليهم كلهم شطار، وكل هذه السبيشالتيز والإمكانيات أكيد موجودة ونقدر نستحصل عليها إذا واحد حب يبلش بهذا البرنامج. الأوثوريتي أبروفال هاي المفروض تبدي من العراق نفسها ومن الناس اللي يحبون يبلشون هذا البرنامج. أما الأفيليشن with well experienced international team، فأني والتيم والبروفيسور ما عندنا أي مانع إنه نقدر نتعاون ونساعد ونأسس ونسوي سيتلمنت للبرنامج بالعراق إذا كانت هاي الإمكانية موجودة ومتوفرة والرغبة موجودة في المستقبل. وبالأخير بس اللي يحب يقرأ أكثر عن هذا الموضوع، أني نزل لي بالأخير بشهر 5 ريفيو ويا بروفيسور ماتس برينستروم على الموضوع، وبشهر 9 إن شاء الله التكست بوك الأخير للريبرودكتيف assisted reproductive technologies راح يكون أكو تشابتر خاص عن اليوترس ترانسبلانتيشن، وراح أكون أني أيضا ويا البروفيسور والكوليجز واحدة من اللي كتبنا هذا التشابتر اللي راح ينزل بالكتاب القادم. وهاي الصورة مالتنا بالمركز، هذا البروفيسور، وهاي مالتنا المديرة العامة والبروفيسور وأني. When a thing ceases to be a subject of controversy, it ceases to be a subject of interest. وهذا الموضوع كان يعني معارض من قبل كثير من الناس بالبداية، وحاربونا وحاربوا البروفيسور، وحتى هم يعني منهم وبيهم نفسهم ما كانوا رافضين ولا زالوا رافضين الفكرة، لكن أنا متأكدة بالسنين القادمة راح تصير أكثر وأكثر وتصبح سهلة مثل الكدني ترانسبلانت وأكثر. وهذه الأماية أول أماية اللي نطت رحمها لبنتها، وهذا الطفل اللي انولد عاش برحم البيبي وانولد من عندها. وشكرا جزيلا.
شكرا جزيلا دكتورة غادة على المحاضرة الرائعة. يعني ما نقدر نحكي، احنا ما نقدر نقول غيرها. أول شيء غطيتي كل شيء، ثانيا موضوع كلش مهم يعني يخص المجتمع، خصوصا المجتمع العربي اللي مثل ما قلت انه يرفضون السورجيت الام البديله وما زالوا. واعتقد طبعا كل شيء جديد يرفض بالبدايه ويتاولوا له، لكن هو كحال اي عضو حيوي يعني هم يعني السوشيال اللي دا يصير ديبرشن للام. وطبعا من محاسن الصدف او ما اعرف يعني اليوم سبحان الله كثير من المريضات اللي اتصلوا اليوم ما اعرف عباك كانوا يعرفون انه محاضره عندنا على اليوتراين ترانسبلانتيشن، يسالون دكتوره اكو يوتراين ترانسبلانت تقدرين تزرعينا رحم؟ احنا عندنا يعني انا استغربت سبحان الله. فدكتوره اذا تسمحي لنا، احنا عندي 2 اسئله على الواتساب جتي لنا مع الاسف، وايد طبيبات كانت عندهم مشكله بالانترنت وما قدروا يدخلون الزوم، حرامات خطيه. بس هم كانوا حاضرين المؤتمر فعندهم. اول شيء من دكتوره هديل علي، she say thanks for very nice and new informative lecture. سؤالها هو what is the time interval between transplanted uterus and its ability to receive an embryo؟
أنا قلتها بالبداية كانت 12 شهر 12 months to be able to consider the stability of the immunological condition of the recipient. يعني we needed in the beginning it was 12 months، لكن later on هذه period shortened، يعني هسه 3 إلى 6 أشهر كلش كافية. إذا البيشنت ما عنده أي rejection نقدر وراها نبلش بالإمبريو ترانسفير.
السؤال الثاني دكتورة آلاء تقول why hysterectomy of a transplanted uterus after 5 years what happened؟
هذا مو لايف سيفنج بروسيجر، ان انا ما اريد اخلي المريضه طول حياتها على الاميونوسبريسنت اذا هي بعد بويضاتها كبرت وما نقدر نستفاد من عندها. عليش دا اخلي لها اليوترس ودا تاخذ الاميونوسبريسنت بدون اي فائده؟ فطبعا نشيلها حتى نرجع حياتها طبيعيه.
زين، يعني between child and other مثلا اذا اخذت 2 child لازم تخلوا لها هم immunosuppressive after
طبعا
one.
هي حتى اثناء البريجنسي تبقى على الاميونوسبريسنت.
طبعا هاي دينجرس.
خلال هاي الفتره كلها لازم تكون على الاميونوسبريسنت حتى على البريجنسي، بس يصير اصلا موديفيكيشن بالدراكس نفسها خلال البريجنسي حتى ما تاثر على الطفل.
سؤال اخر من طبيبتنا منى تقول does she have normal menstruation؟
طبعا هي هذا الحلو بالموضوع. المريضه يعني خلال شهر ما تزرع لها الرحم تجي فرحانه يعني ما مصدقه اول مره بحياتها انه يصير عندها ريجولار منسترويشن، بتنزل مثل ما بالضبط مثل ما يعني امراه طبيعيه وعاديه. نعم She is menstruating normally, regularly. لأن إحنا أصلاً لما نيجي ننتقي الدونر لازم ننتقي دونر ما عندها مشاكل سابقاً بالرحم، والمفروض إنه هالرحم هذا لما نعطيه إحنا هرمونات أو يرجع ينزرع بمكان به هرمونات cyclically، المفروض المريضة menstruate regularly، يعني regularly.
ايه بالسويدي. دكتورة زينب تسأل سؤال، تقول البيشنت يجونا بيشنت they have no uterus congenital absent of uterus، تفيدهم هاي العملية؟
إذا عندهم functioning ovaries نعم طبعا تفيدهم، على إنه الجنرال ميديكال كونديشن يعني مثل ما قلت شلون السكرينينج اللي احنا نسويه، هي مو فقط لازم البي ام اي مالتها ما يكون اكثر من 35، لازم الاي ام اتش مالتها يعبر فوق الواحد، لازم يعني عمرها ما يكون اكثر من يعني هوايه اشياء لازم تكون موجوده حتى نقدر نسوي انرولمنت لهاي المريضه. مو اي مريضه نقبلها، بس طبعا اذا متوفره الظروف هاي تنقبل المريضه، وياهم اكثرهم كل شويه.
العفو دكتورة غادة طبعا. Thank you for nice information. If there is any chance for spontaneous pregnancy after transplant?
لا، لأن إحنا ما نرجع التيوبس، الرحم يترجع بدون التيوبس، فماكو تيوبس. There is no chance for حتى هم ليس اكو ريسك for ectopic pregnancy. فهذه يعني الديسيجن اتخذ من البداية إنه اليوترس اللي to be transplanted is transplanted without the tubes. فماكو.
Okay. يعني only cervix and uterus.
cervix.
There is no vascular connection with the tube and ovaries.
لا الاوفريز مال المريضه هي نفسها، احنا اللي راح نجيبه من الدونر هو اليوترس with الفاسكوليتشر with السيرفكس with الفاجينال فولت، حتى نقدر نسوي انستموسيس بين الفولت مال الريسيبيانت والدونر.
Yes. Nice. Any question؟ طبيباتنا طبقنا عيني.